questions of you because you've had a lot of people in our Center for Morton's Neuroma group contact you as they were contemplating whether or not they should go for having a PRP. So I'm kind of jumping ahead a little bit, but I know that, again, if this isn't a convenient time and then we don't have as many Q&A as we might want, I get Q&A all day long, and I know you're an expert there too. So to those of you who might be tuning in right now, my name is Wendy Williams. I'm the educator at the Center for Morton's Neuroma, which is a program of care within a chronic pain practice that Dr. Janet Pearl is the chief medical officer out here in Framingham, Massachusetts, which is about 40 minutes due west of Boston. And anybody that comes out here from another town or another state, we try to direct them over to Fenway Park so they can see the Red Sox if they're in the right season. And I'd like to introduce everyone to a friend and a former patient, and his name is Matthew Beck. And Matthew is coming to us from the west part of the country, and he is happy. I don't know why so often, but he's happy to talk with anybody that says, Matt, can you tell me a little bit more about your experience with your pain and how these particular approaches that we use here at the center have been helpful to you? So, Matt, thank you so much for your time today. I really appreciate it.
Absolutely.
Yeah. So we are recording this, and I can't even believe that I actually figured this all out with your help. I'm not that techie, but I do all right. So if anybody's on and they want to ask questions, it should be available inside the window. We're doing a Zoom technology through Facebook Live, and there should be a way for you to ask questions. So, Matt, maybe I could ask you to look at the actual Facebook page, and I'll look at this Zoom option for any questions that might come our way.
Yeah, sounds good.
Yeah. So, being that you're here and I'm here, what I think that would be really, really helpful is for people to kind of hear a little bit of your journey with the pain of Morton's, even before you even had the surgery that didn't work very well. But just what was it like, and what age did you start experiencing pain, and how did it show up in your life? How did it look?
Yeah, so my story is an interesting one. I had started to experience pain it was about 3 years ago. For about a year and a half, went through all the common treatments of getting some of the traditional alcohol injections, a bunch of cortisones, a bunch of different pads, adjusting my shoes, all different kinds of treatments that didn't seem to do anything. And so not knowing at the time about the center or other options outside of kind of the traditional podiatrist recommended options that have extremely high failure rates, I ended up doing the surgery and had an operation on 2 neuromas side by side in the second and third interspaces, where they excise them, essentially cut the nerve out, and then attempt to tuck it back into the muscle.
Okay. And so when you say the traditional things, I get a lot of calls where people say, I got injections already. Yeah. I've already had injections. And I always have to kind of say to them, tell me more. Was it the cortisone injections, which I would call a Band-Aid, meaning that it doesn't treat the problem, but rather and that's not to discount it. It's just to be clear about what it is. It's not a treatment, but the cortisone is meant to take the edge off the pain. And some people have found it to be a really good bridge in order for them to ratchet up their physical therapy or stretches, because the pain is a little bit lower, so it allows them to stretch their foot or whatever they need to do. And then that might be a bridge to feeling better. But those are pain management tools, the physical therapy, the cortisone, the pads, the inserts, stuff like that. And if they work, great. If that allows you to not think about your feet or to live the life that you want to live without, worrying about things too much, then that's great. But when they don't, then people can graduate to cortisone shots. From cortisone shots to a sclerosing. So you had that, huh? I don't think I knew that. Yeah.
I went through, to be clear, I went through only the cortisone injections, but I did them both initially without ultrasound guidance. Then I went to a different podiatrist who did them with ultrasound guidance.
Gotcha.
And after that, I did the metatarsal pads, custom orthotics, many physical therapy, all of those things that hopefully for some people work, but for me and for many of those who've had this for a while, it was too far past those types of treatments. So they weren't really effective at all.
Right. And if you could look back and kind of quantify hours spent looking for shoes, trying shoes, getting orthotics, buying orthotics, going to these different doctors, trying to well, if you could quantify the number of hours in headspace, right? I ended up going to 3 different podiatrists until I had my surgery. Yeah. So, and none of which could get to what I needed to help me out, essentially. Right. So, right. Because at the time, I mean, you're barely over 30 now, right? Yeah. Yeah. I was 28. You were 28. 28. Yeah. It's not really the ideal age for you to be sitting with your feet up with ice packs. That's right. More hours of the day than not, right? Yeah. That's right. Right. I mean, I don't know that any age is a good age for that, but certainly not. Yeah, no. Mid-20s. No. So then you had the 2 neuromas, lucky you, 1 foot, 2 neuromas side by side. And you had the surgery back in, I think it was February, year and a half ago. Yeah. So I'd been suffering from the original neuromas for about a year and a half, then had the surgery last March. Yeah. So it's been close to a year and a half when I had the surgery on both of them. Yeah. Yeah. Which unfortunately resulted in stump neuromas in both of them, causing me exponentially more pain and was significantly worse post-op than what I was before pain-wise. So your pain didn't stay, it didn't, when you have surgery, you go, I know the surgery's going to hurt. It's going to take a few weeks to get over it and I'll muscle through that. But after that, I'm expecting a steady increase or decrease in pain and increase in feeling better. So you not only had no difference in your pain, you actually had more pain even after the post-operative window. Yeah, so at 6 months post-op, I was in extreme pain. I was at the 6 to 7 level, where it was very, very, very painful. Wow. Yeah. And so that was going on. So then I know that you just kind of, that's probably where your testimonial kind of picks up online, is where you said, it's unacceptable that you people can't tell me, I'm not going to stay like this. You have, everybody you were looking for in the Northern California area was not really offering anything. No, I didn't see any helpful solution other than podiatrist recommending potentially going back in under the foot. Yeah. To do a different surgery, approach. Which has an extraordinary high risk of failure and additional pain and more complications. Yeah. So you were like, that doesn't sound right. That doesn't sound right. There's got to be something else out there. Right, right. There's been a lady out in the group. I'm not going to use names for anybody around here, but there's been a lady in the group that you may have seen her posting over the past few days talking about the fact that she had decompression surgery, which is different than having the nerve cut and removed. Now, you've done a lot more. Because I don't work in a surgeon's office, I don't delve that deeply. Can you share a little bit about anything that you might know between the difference between the surgery that removes the nerve versus one that makes room for the nerve, which is decompression? Yeah, conceptually, my understanding is that it's definitely less risky because you're not cutting a nerve, right? Which inevitably results in that high risk of having additional injuries and pain. It's a less traumatic. It's not as, there's not as much trauma to the area when they do the ligament release. My understanding is, and please someone correct me if I'm wrong, is that essentially they go and release some of the ligaments in there in order to give some more space so that the nerve can calm down. Right. And give it a little bit more space. I think they call it, the abbreviation is MIND surgery, like minimally invasive something. Okay. All right. And the idea, and I know that a fair amount of extremity nerve surgeons will prefer that over doing the nerve resection because you're keeping the nerve intact. But again, it's a surgery, right? So it's something that for most people, I don't think they ever need to even consider that until they've done the RFA or the other options that we're going to talk about. Because it's still a surgery, there's still a risk of failure. You're still going in there and having cutting stuff. Right. So so in my mind, if they call me and they say my surgery didn't work, for me, it's basically the same thing, except it might not be called a stump if the nerve has not been cut. That's correct. So if the nerve is still firing pain signals and aggravating the poop out of you, and you also have scar tissue, it seems to me that the remedy is basically the same, whether it's cut or it's not cut, which is we need to ablate the nerve or try to deactivate it, pull the plug on it, and give the scar tissue a boost with the PRP and try to make that area less inflamed and more soft and more kind of natural as it was before surgery, and then deactivate the nerve. So the remedy as far as what we offer is going to be the same, whether it was a decompression or a severing of the nerve. Right. Yeah, makes sense. Right. Yeah, that makes sense. So yeah, and I guess what would be helpful is for people to just kind of hear. What I think would be very helpful is tell me what you hear most when people find you on Facebook and they hook up with you and they say, can you tell? I think for me, this is my assumption, is that they listen to me, right? Party line. Yeah. And then they contact you and they go through, tell me the real story and tell me how you arrived at, it makes sense to get on a plane in San Francisco and fly to Massachusetts and have some woman that you're not going to be able to see every week if you need to, work on your foot, and then fly back to San Francisco and feel that that's okay and spend some money. Is that what people are kind of? Yeah,
I get a lot of folks reaching out who are essentially looking for someone to corroborate what they've read online and what they've heard from you and others, and so the perspective I give them is that, when I had and what I'll describe applies to both patients who've had surgery and then it's been a failure, and patients who have a chronic issue and are thinking about surgery, right? And so the idea is that I had spent hours and hours and hours researching a place that I felt like was sophisticated enough to actually deal with this issue. And I could not find any place. I found, maybe one or two places that do some version of radio frequency, but they don't do it with ultrasound guidance. So it's not as accurate, right? So there's a high risk of missing the nerve. Yep. And I didn't find anywhere that adds that additional component of the PRP. So that, the platelet injections where you're essentially healing the scar tissue in the wound cavity where the surgery happened, that's causing the nerve to be inflamed. So I felt like the combination gave me the best chance to deal with what in my case was a very complex situation. Exactly. And I felt like based on, I had reached out to other surgeons and other orthopedics and other, resources, and didn't find anywhere that I felt like was going to give me the best chance to be healed. Because for many folks that have reached out to me, and by the time they reach out to me, they typically had a really, really bad cases. So they're desperate and they found you and they're looking for answers, and it ranges everything from people who haven't had surgery and they can't walk, they can't wear shoes, they can't enjoy their lifestyle, to people who've had surgery like me and are just depressed. They can't believe that from something that should be so simple, they can't walk anymore. They have this incredible amount of pain. So I in general walk them through with what my experience was, which was I found the clinic, I went out, and we went through the diagnostic procedure, which is where Dr. Pearl injects where the neuroma is with a numbing agent. I believe it's lidocaine or something similar. Yeah, something so that she can figure out where the actual nerve is, and if she can diagnose that, she can get it to where it's numbed up and you feel some pain relief, then she knows that she can isolate that particular issue. That's the one, right? Right, and that's important. That's like the first step in the process, right? And then from there, getting into the radio frequency where you're putting the needle and you're essentially, my understanding is you're essentially burning the nerve and making it so that you don't feel the pain anymore, like the pain receptors from the nerve. Again, correct me if I'm wrong on the science itself. Right. Well, all three, the way I understand it, they do it differently. So the alcohol does it one way, which is chemical. The radio frequency does it with heat, and the cryo does it with cold. I call it creating a hostile environment for that nerve to continue acting like a nerve, because basically that nerve has become dysfunctional. And you had two nerves side by side that were dysfunctional. That's correct. Right. And so because 30% of the population is walking around with those little Morton's neuroma on top of their nerves in their feet, and they don't even know they got them. They just walk normally. Right. They feel normal. But for a precious few amount of that 30% of people,
the nerves have gone wacky and are sending pain signal, and telling you, don't put your full weight on the foot. Oh boy, is it bad. It's bad down here. You don't know. You better stop. Because the body is geared for pain to be protective. It's to tell you, stop, retract, go in a different direction, whatever, take your hand off that hot stove, whatever it is, to protect you. And so your people are walking tenderfooted, saying, I can't put my full weight on my foot. It's bad. It hurts. It's telling me, don't do it. It hurts. But that's actually wrong. It's wacky. So we have to deactivate it. Yeah. So you're right. The hot, the cold, or the alcohol makes a hostile environment and stops that nerve from operating because it's going in a bad direction. So we just need to so we don't remove it or shrink.
Right.
Right.
Just remove basically interrupt that feedback cycle. That's right.
That's right. Yeah.
And so a lot of folks ask me too what the actual pain is like and what the timeline looks like.
Okay.
So in my case, my first visit was several months after my failed surgery, and I went in and had both treatments on both interspaces. So 2 neuromas, 2 radio frequencies, 2 PRP injections, 1 in each interspace. If you think about it, 1 between one toe and 1 between another toe. And then
I need to interrupt. You had it in the old days.
I had it in the old days.
Did you hear that?
I had it in the old days.
You had it in the old, and you know what I mean by that? Because in January of this year, so 7 or 8 months ago, Dr. Pearl got some additional technology on campus that once you draw the blood and you spin it down and you get the platelets with all the good stuff at the top, what happened with Matthew was she just took that stuff off the top and put it right into your foot. And it did what it was supposed to do, created fireworks inside of your foot. And it hurts a lot. But with this light source, this new technology that we got in January, we do the blood, we get the golden syrup on the top, as I call it. We put that syringe in this light source and it beams on it for, 7 or 8 minutes, something like that. And the fireworks take place in the tube. So by the time that golden syrup gets injected into your foot area, the fireworks have already happened somewhere else. Yeah. But you, my friend, I will never forget the picture of you hobbling out of there with those crutches. I mean, it was kind of, and I said, I can't believe I'm sending him home by himself on an airplane to, I don't know where. I was, everything in me, my maternal, my womanly instincts were like, don't go, let me help take care of you. But I couldn't. But anyway, but you did fine.
To your point, though, if you recall, I came back. So long story, the plot thickens. Then I remember I had developed a neuroma in my left foot because of compensating for so long on the first foot I didn't have surgery on.
Right.
And I did get that procedure on my left foot, and it was even easier. So I had the RFA and the PRP on my left foot.
Right. Even though you hadn't had surgery. And
even though I hadn't had surgery.
Because you knew that the way that you experienced such an uptick in feeling better with the really crappy foot, if it did that well on the really crappy foot, it's going to do great on my foot that's kind of just at the beginning.
Right. So any patient, so I have experience both with RFA PRP on the surgery foot and then RFA PRP on the neuroma on the left foot.
Yeah.
And both of which went really, really well.
Right. Well, to the degree that, I mean, like what does it look like today for you, for your feet? Do you think about your feet much during the day? Do you?
No, I don't. So it's been remarkable in the sense that I had kind of planned in general. Once you get the treatment done, you plan on about 7 to 8 weeks of healing time with the PRP. And then you really start to see the improvement, which was the case for me on every trip that I went on. About 7, 8 weeks, I saw the nice improvement. And interestingly enough, now that it's been since my latest treatment, 7 or 8 months, I've continued to see even more improvement every single month to where now I'm never thinking about my feet anymore. And it's incredible. I couldn't walk. Now I'm playing basketball and I'm running and I'm cycling and I'm doing all these things. So
you're saying you're hitting the gym pretty hardcore, you said.
I'm back in the gym and I'm jumping and doing all these things that for a while there, I was, really scared that I wouldn't be able to be active again. It was it's crazy.
I remember when you contacted me, I think in February or March or whatever, and you said, I'm playing basketball. I was like, what? It's very exciting. Very exciting.
Really, really exciting.
just because in January you had foot 2 dealt with. So that's why it was so exciting. And what made you think that you needed a second PRP on the surgical foot? Second set of treatments. Tell me.
Yeah. I think in general, Dr. Pearl's advice and counsel is to generally plan for 2 procedures to make sure that everything's taken care of.
Yep.
And I saw a really nice improvement after my first treatment, but there still was pain there. There still was, some annoying pain, and I felt pretty confident with a second round, I could both remove the nerve pain and help out with the scar tissue with the PRP. And there was essentially, no downside other than the time and resources to go. And I felt like that was what made all the difference. I was doing the second time to really get everything in there, take care of it. And that's what really got me to the healing that I needed to get to.
Great. Good. Yeah. I can see that. And I'll tell you though, it's very interesting that sometimes not everybody needs the second one, which is so interesting to me. I'm starting to develop a glossary of terms, shall we say. So when people have neuroma that have never had surgery, I'm calling that level 1. So level 1 is just an ablation. And level 2 is you've had surgery and it still hurts. And so we need to do an ablation plus the PRP to deal with the scar tissue.
Yep.
So level 2 care is the ablation and the PRP. Level 1 care is just the ablation. However, Dr. Pearl is thinking that if we offer level 2 care to a level 1 neuroma, like you did
Correct.
For your other foot,
correct,
there's every reason to think you don't need to have 2.
I mean, that was my case.
And that was your experience, is that you got the level 2 care, the PRP and the ablation on a level 1 neuroma, and you had it done once and you're happy as a clam. Yeah. Now, practically speaking, the PRPs cost $875 and they don't get covered by anybody's insurance to date. Right. I don't know. Maybe that's going to change. Maybe insurance companies will wake up and say,
probably not for the foreseeable future.
Yeah. So the tissue repair is a good idea and keeping people away from having surgery. But that's why, you just don't go say, yeah, you should have spent $875 because level 1 care works. You just need 2 of them. However, if you're coming from San Francisco to the other side of the country,
just get it done.
You might spend on the second trip, you're going to spend $875 on your plane trip, maybe, or $875 on your hotel bill, costs, or other costs are going to add up. So why don't you just glom it on there, and let's all hope that you only have to come up the one time.
That's my recommendation, and I mean, for everyone's financial situation is different, and the schedule is different. But if you can, I think that's especially for those that have suffered for a long time. Many people say they're willing to pay whatever it takes. And that would be my advice is if you're going to go out there, make it, hopefully you can find a way to save and make it work because it's really, really, really helpful. Right. Good. And it what? Well, as you're saying, and it just makes it, it's just totally worth it. It makes it, for the ability to walk and run again, to put a price on being able to be active, especially for a lot of folks that have reached out that are active people. The woman was talking about she couldn't go run with her daughter and wasn't able to spend time because she was in a boot and she was in icing her foot and in so much pain. And I just, nobody wants to live like that. No, it is. It's really amazing. And one of my favorite expressions is if you're thinking about your feet more than 17 seconds in a given day, that's too long. Because most of us just get up and put on shoes and socks and go about our life, which is the way it should be. I mean, it would be sort of like if you had a hangnail in your pinky finger and all you could think about was your pinky finger all day long. You're at work in a business meeting and say, I got to figure out this hangnail. It would be great if you could forget about the hangnail and pay attention to what's going on in the room at your office, or pay attention to when your child is trying to tell you a story about what happened at the office or school that day, whatever you want to say. If your mind is constantly thinking about what shoes, what this,
should I do this? Should I not do that? Should I have surgery? Do I like this podiatrist? Do I not like this? I mean, oh my goodness, just the time, just the time.
Just the time. Wendy, we got a question. We got a couple questions here. It looks like from Deborah Sherman asked a question. Does RFA have the same long-term effect as cryo?
Yes, both the radio frequency ablation, the cryotherapy, and the alcohol have all been in the studies, and they are all 85% of people who have two of those treatments have basically the same results. So whether it's alcohol, cold, or the RFA, two of them on average reduce the pain by at least 50%. That's the giant statistical salad, shall we say. And that includes older people, younger people, people who've had 17 neuromas, people that just got their first one, people that get the alcohol, so yes, the studies are showing that they really are equally effective. And typically what makes Dr. Pearl and you, the patient, decide which one makes the most sense. I always tell people these two things. If you're a woman with particularly tiny feet, we're not going to use cryotherapy because it's an ice ball. And if you've got really tiny little feet and little tiny ligaments and little tiny bones, then putting an ice ball in there, there's a very good reason you're going to get frostbite. Not doing it if your foot's too small. Or let's say you have places to go and things to do. You have a trip plan, let's just say November 1st, and it's August. And you're like, I've been planning this trip. I've got $1 million invested in this trip. It's all about walking up the streets of Italy, and I can't deal with it. My feet hurt. Then we might suggest getting the alcohol, because the alcohol reveals its effectiveness after 3 weeks. So you could get 2 in before November and start to feel really good and go on your trip. But if you did 2 7-weekers, you might be kind of courting, like, I don't know if I'm going to feel well enough by the time I want to do all that climbing. So those are a couple of the reasons. But yes, Deborah, all three seem to have the same outcome data in the studies.
And the studies are linked on the website. If you go in, you'll be able to see the reference in PDFs. And
that's right.
Look at the study.
That's right.
Janet had a quick question. She said she has Solda had Morton's neuroma nearly 4 years ago. She's had injections in her foot, but had an ultrasound and now been told it's not a Morton's neuroma. Could the ultrasound have missed a Morton's neuroma?
Yep. So in general, Jenna, the imaging studies are not particularly dead on reliable to say yes Morton's, no Morton's. That's why what happens when we do what's called the diagnostic injection is referred to by our website, and I think probably other resources or sources, as the gold standard of Morton's neuroma diagnosis, because you can see a Morton's neuroma on let's just say, like I had an x-ray a year ago for my foot because I broke a toe. And if the x-ray showed a soft tissue neuroma in my pinky toe, which is not where I got the break, and my doctor might have said, did you know that you have a swelling? Maybe it's a Morton's neuroma in your toe. And I'd be like, no, because 30% of the people walking around are asymptomatic. They don't even feel them. Now, if I have all the, a lot of the bells and whistles, shooting pain, numbness, can't keep my shoes on, maybe feel like I'm walking on a stone or a rock, and they do an x-ray or they do an MRI and they don't see it, that doesn't mean I don't have a Morton's neuroma. It could just be so tiny that it's causing all the trouble. So the size of the neuroma doesn't mean size of pain. You can have big pain, teeny weeny neuroma, kind of a little bit of pain, huge neuroma, or no pain and neuromas. They're in there, but they're not causing pain. So the imaging studies are not predictive. They're not really helpful to really say, there it is, go get yourself a radio frequency ablation. And even if they did say, oh yeah, there's the neuroma, I've had an MRI, neuroma, X-ray, neuroma, ultrasound, neuroma, even if all three showed it, nobody worth their salt is going to go in and give you a radio frequency ablation into that neuroma without doing some ultrasound guidance themselves to isolate it appropriately, if that makes sense. So I hope that was helpful to you. And if not,
that's a good question.
Follow it up.
The next, we had Elamar, forgive me if I'm mispronouncing your name, asked, she says, wearing Birkenstock shoes and find them helpful. What type of shoes do you recommend? I found Birkenstocks to be super helpful. I wear those as well. Mm-hmm. But now I wear Nike. There's I believe they're called the Nike Free Skylux. They have a very thick sole. Yeah. Which I found to be super helpful for me. And then I got some dress shoes that have some really thick bottoms, and I'm doing much better now. I'm wearing shoes that I wouldn't be able to wear previously. Yeah. But the idea is you, in general, want a wider toe box. That's going to allow it so your toes can spread out and allow you to have some space. And then cushioning certainly helped me. Yeah.
So can you repeat the name of the sneaker you use again? Slowly.
Well, the ones I got were the Nike Free Skylux.
Oh, Skylux. Skylux.
Yeah, and the models of Skylux.
Okay, and I've heard also, and I know from other patients talking the word LEMS shoes, LEMS, LEMS shoes, and they're more of a tie Oxford sort of a shoe rather than, they could have more of a sneaker, but I know that they're more of like a shoe, but LEMS is as opposed to a sports shoe. So LEMS is a good option for people. Along with the Birkenstocks, I've heard a lot of people comment that those have been helpful too. Anything else out there? Anything else out there now? Nope.
No, not anything right now. Thanks for having me, Wendy. I really appreciate it.
Yeah, I really appreciate you spending the time with us, and hopefully we got to a lot of people's frequently asked questions. If I could just beg you for 30 seconds. You said once you found Dr. Pearl, you went. Was there anything between, what made you say, I'm going to get in a plane and go to Massachusetts?
It was my confidence in the research on the site and the degree to which it was clear that Dr. Pearl had studied the issue and that they were offering both an approach and a technology that nobody else could even comment on. Yeah. And that to me was an indicator that they're doing something forward thinking and they're figuring out a way to address this issue that nobody else is doing. So it's worth it.
Right. And you were able to see that she was building off of a recipe that had been tried and true in the medical literature. That's right. Like, one thing I tell people, this is not proprietary. Dr. Janet Pearl didn't make this up. She's just following a really good approach. And wouldn't it be great if others did too? But we're here. We're doing it to the tune of 10 to 15 a week, I think, at this point. Wow. And we're glad to be helping people out. So thank you again, Matthew. I appreciate it. And if anybody wants to give us a call, I'm at 774-421-9144 in the United States. All right. Take care. Thanks again, everybody. Yep. Bye.